Is there enough light?
Yes, yes, you're all right, ma'am.
I'm okay.
Looks good. Yeah.
So until we start, we can mute.
Sure. Yeah. Yeah. The Surgical Society is Glenn, huh?
Yes, sir. Yes, sir.
Oh, yeah, that's one. But there's another surgical society. Is that Wasim again? Wasim, why are you?
Yeah.
Why do you keep going back to surgical society if you're still there? Or is it Amul Raj?
No, no. It's uh, myself, sir.
No, there is another Glenn Williams higher up. That's not surgical society. Oh, this is must be Harish. Harish. Harish,
Yeah,
can you
doctor.
please rename yourself?
Uh, no, sir. Today,
Hmm.
since you told me that I never entered my, I didn't enter through my laptop or mobile, sir.
So who is the surgical society then? Who is a co-host? It must be either Wasim or Glenn. Glenn is already separate, but I don't see Wasim's name, so he must have gone. Wasim is there in the end. Amul Raj, are you
Yeah,
there?
must be Dr. Wasim only, sir. No,
No, no,
no.
no.
Amul Raj
Wasim.
is not there, sir.
Then who is the surgical society? Is it Venkatachala? Is it? I don't know.
So from YouTube, we are ready, sir. I'm Wasim only, sir, in this. I'm not in the. I've logged in as Wasim. Nothing else.
Yeah, I know you are Wasim,
Yes, sir.
but there is another surgical society.
So you exit
I'll,
him from the group. You, I think you're the.
I don't want to exit people, but I'm just saying who it is. I would like them to
Change.
Yeah,
Yes, sir.
change. That's all.
Sir, I've been trying to start from the laptop, but it's not coming. So I did it from the mobile.
Oh dear.
So
Now, why
that's
should
the
it be
problem.
difficult, Glenn? These things, please learn, or you bring it to my house. I'll teach you step by step. It's so many months since you got it. You must get up to speed on this, please.
Maybe because of the internet speed or something. I
No,
don't know.
do you not have cable? I thought you had cable in the SSB office.
No, no cable.
This is from my mobile. I have connected.
Maybe you're connected
It's
from your
not
laptop
connected.
also without your knowledge. Maybe that is what is saying Surgical Society.
Yes, sir. Yes, sir. Yes, sir. Okay, I'll do from the mobile only.
But I don't have Harish as a separate. You must be Surgical Society, Harish, because
Sir,
I
since
don't.
this meeting,
If you have come in as Harish, it should be saying Harish, but it is saying Surgical Society, so it must be you.
sir, I am using my wife mobile today because see, even if I enter through my mobile,
Hmm.
it was showing a surgical society. Then laptop also showing surgical. That's why today I using my wife mobile to do this.
Then what is her name? It is not here. Even your wife is saying Surgical Society. You work so hard for the society, Harish, that everything in your house is only Surgical Society. Huh?
Yes, sir. What I will do just sir, is
No,
it
no,
okay?
don't. No, it's no big.
Okay,
Harish,
I exit and
Harish,
re-login.
Harish, please listen to me. It doesn't matter one little bit. I was just pulling your leg. Leave it as it is. Please participate.
Yes, sir. Thank you, sir.
Absolutely no problem
Thank you,
whatsoever.
sir.
Yeah,
So,
yeah.
Sir, Lakshman sir,
Sir.
even my laptop, when I put that ID number, it was coming as invalid ID number. Then the same number got connected to my mobile.
Uh-huh. I don't know what the score is. Yeah.
Yes.
ಹರೀಶ್ ನಿಮ್ಗೆ ಹಿಂದ್ಗಡೆ ಲೈಟಿಂಗ್ ಇದೆಪ್ಪ ಏನಾದ್ರು ಆ ಹಿಂದ್ಗಡೆ ಲೈಟ್ ಆಫ್ ಮಾಡಿಬಿಡಿ
yes, sir. Yes.
ಮುಂದ್ಗಡೆಯಿಂದ ಇಟ್ಕೊಳ್ಳಿ ಲೈಟು
Yes, sir.
You guys aren't seeing anything, any gray rectangles on the screen, right? You're seeing the screen as it should be. Yeah. No gray rectangles to be seen. You're seeing, right?
No.
Yeah, because I have the chat box open and all that, and that should not be seen to the others. That's why I'm just double checking. Yeah.
Good evening, sir.
Good evening, President sir. Welcome.
Easier.
What is there?
Today, easy entry.
Easy entry. Yeah.
There was some request from SSB to log into their Zoom account. So I came out of that.
Yeah.
Created my own registration.
That is the best.
I
Yeah.
have my own account now.
Yeah. Ashok Godi avarge the last minute he had an emergency, so he couldn't join Venkat. So I have requested Rajan to please
Yes,
stand
sir.
in.
Good evening, Rajan, sir.
Graciously agreed, and we are.
He's
we're
always
grateful to him.
our man
Yeah,
Friday.
yeah.
Good evening, sir. Rajan, sir. Harish, good evening.
Sir, good evening, sir.
Good evening, Nirmala, madam.
I'm not feeling bad because India losing many wickets at the test match. So
Are they? Okay.
I thought they were scoring good at around 97 for no loss.
From 98 for no loss, they've now 114 for 4.
Oh.
For 4.
Good that I was not watching.
So Virat Kohli went out the first ball to Anderson. Very first ball.
Okay.
Caught behind.
Shivaram, sir, good evening. Jogarao, sir.
Good evening, Shivram.
Good evening, everybody.
Evening, doctor.
Yes.
Purushottam, sir, good evening. Any new login, you get a beep, is it?
Normally, no. I don't know why it's happening. Honestly, for some strange reason, the
settings changes.
settings are getting changed in our SSB.
People while learning there.
Yeah, that's happening. So,
The beep during login and the settings, host must change that.
yeah.
Neil, host.
Yeah, it doesn't happen to the meetings. It should be at the user level ಅಂತಾರಲ್ಲ main account level ಅಲ್ಲೇ ಮಾಡ್ಬಿಡ್ಬೇಕು. 7 ಗಂಟೆ ಆಯ್ತು, ಶುರು ಮಾಡ್ಬೋದಾ?
Yes, sir. We'll start, sir.
Right, sir.
Just one sec. Please start.
Recording.
Please start, President.
Good evening, everybody. On behalf of Surgical Society of Bangalore, I welcome you all for this third edition of this virtual panel discussion on ethics in surgery. Dr. Lakshman has been doing a very good job, and Dr. Joga Rao, Dr. Rajan is here, Mrs. Nirmala is there, so, and Dr. Gurushantappa. So, sir, Lakshman sir, please take over.
Yeah, thank you. Thank you. Good evening, everybody. I would like to begin by thanking the SSB for giving us this opportunity. I do this on behalf of myself and all my esteemed panelists. We have indeed a distinguished panel today. Professor Godi, unfortunately, I was called for an emergency surgery, so he's not able to come in and participate, but Dr. Rajan was very gracious in agreeing to stand in for Dr. Godi, and that happened literally 10 minutes ago. We are very grateful to you, Dr. Rajan. We don't, Bangalore audience doesn't need an introduction to Dr. Rajan, but one of our very good friends and leading lights in the working of Surgical Society of Bangalore, a very renowned surgeon, and I must say that one of the biggest proponents of ethical practice of surgery in the country, I might say. Dr. Godi, of course, is unable to be here, and he sends his regrets. And we'll start with a brief introduction of our panelists, other than Dr. Rajan, of course. Mrs. Nirmala Murthy is the founder of the Foundation for Research in Health and Systems, and will be the voice of our patients in some of these difficult ethical situations that we are going to discuss during the day. She is very well qualified, a doctorate from Harvard, and has been a faculty at IIM Ahmedabad. Dr. Joga Rao, of course, is known for his skills in and knowledge in medical legal field. He was he started the medical legal fellowship course at the National Law School, University of India, Bangalore, and presently he anchors the professional activities at Legal Excel. I'll skip Professor Godi because he's not here today. Professor Guru Shantappa is an extremely knowledgeable and proficient surgeon who has made a name for himself as an excellent teacher, and we see his skills and his capacity as a teacher and as a surgeon on a regular basis in our teaching programs. It's indeed very nice of him to have agreed to be on this panel, and we thank you very much, sir, and welcome to the program. He's presently serving as the HOD, Head of the Department of Surgery at KIMS Hubli. Thank you, sir. A brief thing about the ground rules. Please put the comments in the question box. I will be following it on a very regular basis, and we will either answer you in the question box, in the chat box, or we will get you to, if you raise your hands, we will invite you to come on to the unmute yourself and come on to the program and voice your views. Ethics being what it is, particularly in a very contentious issue like this evening's topic, there will be disagreements. You cannot expect universal agreement on all issues. Let our disagreements be very civil and very muted. The point has to be made, and I think we are all very mature, and I know the last two programs have shown that we can be actually very, very nice in the way we discuss things. There will be limitations. Each one of the topics, 3 topics I'm going to talk about today, are is a topic for a whole 2-hour discussion by itself. But we don't have that much time, and so we'll keep it short. If we ask you to be brief, or if we ask you, or if we don't give you an opportunity to talk, kindly don't misunderstand me. What we're going to talk about today are 3 things: communicating bad news, advanced directives, and end-of-life care. Each in itself is, as I said, an important topic for all of us as surgeons to learn. Communicating bad news is an art, and that has to be learned, because every day of our lives we keep talking to our patients and their relatives about possible big time disability, possible big time infirmity, maybe even death, or we may even have to talk about complications of surgery and death itself. And it's shown in many studies that doctors themselves are very uncomfortable about communicating bad news to patients. And so it is a skill that we have to learn, and we will have a discussion today and talk about it and see what are the things that are required to communicate a bad news to a patient or a relative. And of course there are many gray areas. Certain things are to be told, certain things people feel are not to be told. How do we approach it is the question. So let me first talk to our panel. Mrs. Murthy, from a patient's point of view, if somebody is communicating, if a doctor has to be communicating bad news to you about yourself or your close relative, what do you expect of him? Please unmute, ma'am.
We pray that it doesn't happen, but now that you ask me, for anybody, any patient or any family, hope is that we are not going to, some not very bad thing is going to happen, is sort of at the bottom of everybody's mind. And going to doctor means he is going to save me, and the bad thing will not happen. So that's how the patient is looking at it. So the communication that I want to know is that something that will not shatter my hope, that it will tell me whatever news with a rider that yes, it can be different, it can be improved, you can do something, but not shattered completely. That's one thing that I would expect.
All right. Would you expect him to be truthful about the actual outcomes as he expects them to be, or do you want him to color it so that it doesn't shock you?
Shocking is something I would not. I mean, depending on the capacity of the person to tolerate the news, the shock part would like to be blunted to some. Because once the shock comes, then the person's ability to even withstand or to sort of hope or try to sort of overcome that problem is shattered. And so I would expect that, yes, truth, depending on how much or who in the family can understand or tolerate the truth.
Right.
If the patient cannot, then you shouldn't shatter.
Yeah.
So that's a hope is the main sort of strength on which the patient's treatment I would expect to happen.
All right. Thank you, ma'am. Rajan, can you come in and say what you would do? Unmute Rajan, please.
All right. Communicating bad news is always an important aspect of our clinical care, because whatever you do, there will be the cases where it does not go according to plan. So one of the things is, when you find such things likely to happen, have a strategy in mind. And the most important strategy in mind is to ensure three things. One is a privacy in the communication. Pull them aside, make sure that there's nobody else talking, make sure that they understand it. Secondly, introduce the topic. Don't directly tell them. Tell them that there is a situation which needs to be discussed, and the outcome of that situation will be mentioned in this discussion. And we will start it off like that, rather than saying, I've got bad news for you, the patient is not doing well. You have to layer it a little bit. And thirdly is to show the empathy, the sympathy, the understanding that you too are in their shoes of emotion when you are communicating this news. This is very important, that the patient and you are on the same plane. And as Nirmala Madam had mentioned, speak to the most responsible person for the patient rather than the most emotional person of the patient. And that way it helps to get this bad news communicated. This is my little take on it.
Dr. Guru Shantappa, sir?
Sir, I do agree with Dr. Rajan, but to add to this, if I'm suspecting that there is going to be a problem with that particular patient and the particular surgery and the particular disease which I have treated, I'll be planning this well before, maybe few hours before, maybe a day or two. So from that point only, I'll be starting this issue, taking one of the person who is more responsible, giving all the details, and I will have my number of visits will have more frequent visits with a documentation in the case paper. And every time, whenever I visited, I'll make it a point that I'll inform my visit and what is the outcome to that particular person. And once it comes to the point of stage of no return, or where we cannot revert back that particular patient, like what Rajan said, in a privacy, forgetting all the remaining priorities of the work, with keeping mobile off or out of the way. And then I'll think that, yes, I'm one of the part of the family member to them, and I'll speak to them nicely. And the one more person who may be like, if it is a female patient, one male other person, or a more responsible person, I'll describe in diagrammatic manner what all has been done and see that they accept, rather than conveying straight with that patient is mad.
Dr. Jogarao?
I think while echoing all other panelists what they have said, I just would like to add one important point. I think this is from the legal perspective. The autonomy of communication is given to the treating doctor. What to communicate, what not to communicate is absolutely the treating doctor's clinical autonomy. The only thing is, kindly consider the underlying condition of the patient and take the family members into consideration. And then, as Dr. Rajan very rightly said, you need to strategize. I think that is something, that is the only.
Venkat, as an oncosurgeon, you will be giving the bad news about cancer to practically every patient of yours. How do you approach this?
Really tough, but fortunately many patients already come with the reports. They will know the diagnosis, and some of the times the relatives will know, the patients may not know, but we have to go it in a, if the news is good, like something like a thyroid cancer, it is easy to convince them, easy to explain. But something like an advanced malignancy, it becomes very difficult. All the information cannot be given to the patient because the patient may not be in a state of mind to accept a stage 4 disease or metastatic disease, and they may not agree for treatment if they know that they may not survive for long. So the best person in the family, the most knowledgeable or the most reasonable person who is emotionally strong enough to take the news, we have to communicate with them first. I'll ask from the relatives, what is the overall coping capacity of the patient? How anxious
All right.
they are.
Okay.
Once you find out that, then you can slowly go to the patient.
Slowly go to the top. Yeah. Now let's look at some of the aspects, the theoretical aspect, but extremely important, that whenever you give bad news, which is defined as a news that drastically and negatively alters the patient's view of his or her future. It must be drastic, it must be a negative picture that it is painting, and that is bad news. Everybody goes through this reaction called the grief reaction. It initially consists of denial, then they have anger. Why me? Why should I get it? I've led a good life, I'm an honest man, why me? Then starts bargaining with himself and with God and with the doctor, whoever. Then they go into depression, and finally they get acceptance. And while everybody goes through these phases, the duration of each of these phases is extremely variable. That's where people differ. They may be in denial for a long time, or they may be in anger for a long time, whereas another person may go through all these phases and come to acceptance within a day. So what happens is that the phases are the same, but the duration is extremely variable, and this variability is what gives doctors the challenge to understand and face each person as he is and understand these phases. You must know what phase he is in before you give the information. Yes, physical surroundings is very important. You must have a private, quiet place. Our panel have mentioned this, but I'm just summarizing it for you. It cannot be done over the phone, and it must be uninterrupted. Switch your phone off. Professor Guru Shantapa mentioned that. You must turn your on, you can't keep getting disturbed when you're talking about this. And everybody mentioned about the buddy. Somebody who is responsible, whom the patient trusts. Body language is very important. I would stress that, good eye contact. And as you know, 60% of communication is body language. It's not words, it's not verbal. And the empathy that Rajan spoke about is something that comes across the way you hold yourself, the way you sit, perhaps hold the patient's hand, look him in the eye and tell him that you are putting yourself in his shoes and you understand what he is going through. And that is where showing empathy is something that we need to, and give them time. See, if you keep blurting out prognosis or this or that, one after another, it doesn't work. Could the co-hosts please mute others? Wasim and others, please mute others who are coming in, please. Yeah, thank you. Please do that job because I'll need to talk. Yeah. So let the news sink in, give them time, and if there are periods of silence, don't worry about it. The patient is thinking, he's not able to articulate. Give him the time, and this is the very important thing. Whatever happens, you're there for him, and you will make everything possible to make his life comfortable, if not anything else. What is very interesting is, and I'm going to put some clinical scenarios that we all face every day in the slides to come. Large majority of patients want honest disclosure, particularly of cancer. Large majority, 3/4. Many want their families involved, but only about 50% of the families really want the truth to be told to the patient. This is a survey from India. Many people want a full disclosure. This is the context of talking about blunting the blow, as it were. Mrs. Murthy spoke about it. I don't want to be shocked. I want it to be modified appropriately. But many people want full disclosure, and instead of talking about long-term things, what happens 6 months, 1 year, 2 years later, at the time you are disclosing the bad news, it is good to talk to them about immediate steps and outcomes. And as I said, one of the most important things is to make sure that they will be comfortable. And many times, particularly the mention of the word cancer, people think that they're going to die the next day or in a couple of days. You can tell them that many cancers are curable, many things are good, and assure them that things will go well. So we come to the actual clinical scenarios, and it's a very, very common thing that we have. You have an elderly lady with widespread disease. The son asks the doctor not to disclose the diagnosis to the patient. Everybody knows, the patient herself suspects, she is knowledgeable, she knows, and she would want to know, but
Right now I am on some ethics panel discussion.
Raja? Yeah. But the son says, don't tell the patient. Here, if you don't tell the truth to the patient, particularly when you know that she wants to know, you are violating the patient's autonomy. How do you approach this, sir? Dr. Guru Shantappa.
Sir, disclosing the events to the patient, I will have my own way of doing it. It depends on the case, what I am facing. If it is for example, to take CA breast or CA thyroid, because you have taken a widespread cancer, just I will mention 1 or 2 points pertaining to the cases. So if it is a case where it is going to come in the way of their cosmesis, or where we are expecting some changes in the post-operative period, first I will give all the details to the patient relatives, see that they understand. Then part of it, I'll inform the patient what is going to happen after surgery, because they need to know that. It should not be a surprise straight away after the surgery that breast is not seen. Okay, if that is a case. If a case like this, which I have given here, example with a widespread cancer in an elderly patient like this, probably I feel it is really not required everything to be told to the patient. If the patient relatives like son and the one who is going to take the responsibility, if they can know all the details of this particular disease, probably that should suffice, because ultimately we are not going to do anything active from our side to that particular patient, so that probably it will not come in the way of discussion. So right. If the relatives know all the details, probably they will accept.
If the patient asks you, doctor, do I have cancer? And just before that, the patient's son has told you outside the room, sir, I don't want you to disclose this diagnosis to my mother. How would you react if the patient asks you, do I have cancer?
I will simplify in the sense, I'll just mention them that yes, I have spoken in detail to your son. Nothing to worry. You have a major illness. Probably everything should be all right. Right. Both of us, your son and myself, will take care of you. Don't worry. You just follow your son's and our instructions. Everything will be all right.
Very nice. Rajan.
Surprisingly, I have noted, and I've had the experience of patients thanking me for telling them the truth. In spite of the relatives saying, no, don't do it, you go to the patient and quietly and tell them, listen, life is always has a beginning and an end. The end varies with different kinds of people. It comes early for some, it does not come early for others. With that kind of language, you tell them that there is an issue that has started your days towards the end of life. And luckily, we have some modes of treatment that will help you to have quality life, and leave it like that. A week later, 10 days later, the patient says, "Sir, thank you for telling me. I am now able to deal with the problem." And so we have to balance it according to the situation. There's no ground rule for everybody. Thank
Right. Mrs. Murthy? Mrs. Murthy, are you there? Can you unmute? ma'am?
I am there. Yeah, I am
Yeah.
unmuted. I very much agree with Dr. Rajan. It so much depends on the patient and her ability or preparedness to hear. I know cases where my own mother, for example, she didn't. She knew it, but she didn't want to be told the details, and she left it to us to decide whatever is good for the treatment. So if there is so that depends on the patient. But there is another person who then decided, I don't want to be treated. They say there's not much, I don't want to suffer this. I lived 75 years, enough. My son died recently. I don't want to live. So there are a lot of other considerations come for the family, patients, where knowledge is important.
Jogarao?
I don't think there can be a general response in this. Patient to patient, context to context, number one. My only concern is, as a patient, if I would want to know, if doctor doesn't disclose because my son wanted him not to disclose, I think my autonomy has been compromised.
Yeah, yeah. You know,
I know, if I know that I may not live for the next 1 year or 2 years, maybe certain things I want to do, certain things I want to, and as Dr. Rajan said, yes, that is how I compare with acceptance, and let's see whatever can be done, etc. Somewhere down the line, that's my concern.
Right. No, that is a very valid point, because in the Western, this is where cultural differences occur, where ethics has to take into consideration the society and the, as I said, the temporal, the time of the whatever that we're considering, the time scale. In the West, perhaps most people are very autonomous and they are very clear, and their thinking is as follows: the two people from a patient's perspective, the two people I trust the most is my immediate family and the doctor. And if these two people do not tell me the truth and the whole truth, where do I go? Who is going to help me? That is the kind of thinking they have. And I agree that our culture is perhaps a bit different. And so there is a little difficulty. Before I tell you what I do, can I bring in Ravi Shankar, please? What would you do, Ravi Shankar? Are you there? All right, Shivram?
No, I am there, sir. I'm there.
All right, yeah, please come in, yeah.
I think the problem, I think you put it very succinctly. There is a huge...
Keep it short, please, Ravi. Yeah.
Huge cultural difference between West and India. But if there is a patient who has a multiple metastasis and widespread disease, there is not much point in the patient knowing about it as such. As long as you are taking care of the problem and palliating the patient well, and the family knows about it, I think then there is no need to disclose this, I feel, because from a human point of view.
Before we move on, I will tell you what I do. I actually tell the same story to every single son who says don't disclose the diagnosis. I tell them, look, you and I are the two people whom the patient trusts the most. If we don't square with them, they will really feel desperate and very, very uncomfortable. So many times when I say this, my sons, the family understands and they allow me to talk to them. And I always say, it doesn't have to be as bad as it actually is. That is where the white lie comes in. And that is where the hope that Mrs. Murthy spoke about. We don't have to say, stage 4 disease, you're going to die in the next 3 months. In fact, we won't know even if it is stage 4. But instead you say, look, we have now determined and understood with the tests that you have cancerous cells. The word cancer need not worry you. There is always treatment, unlike the olden days. Give them hope, but at the same time, you have not told them when they ask you straight, doctor, do I have cancer? I don't have to either evade that question or tell them a lie that they don't have a cancer. That is the kind of approach I usually have. Okay, and these are all little variations on the same kind of scenario, because we face this in every day. The bad outlook in a patient's ICU is communicated to the patient's children by the doctor. It happens all the time. Okay, and the patient's brother, okay, protests and lodges a complaint that there is no communication from the doctor. What I mean is, there will be several relatives involved with the patient, and whoever comes to you, you of course make sure that they are the immediate family, you talk to them. But then there will always be somebody, maybe one or two other people who are not there at the scene earlier, but who come later and then bitterly complain that they have not been informed properly. Joga Rao, how should a doctor approach this?
Law has never mandated that whosoever represent the patient in terms of member, all the members need to be informed. No, it is practically not possible for any doctor or team of the doctors. That is the reason why when a patient is in a particular condition, what is expected is, let the family members decide the news whom to be communicated. You decide and accordingly inform and ensure whenever the counseling session takes place, those members are there. I think the patient's brother filing a complaint is absolutely unwarranted and deserves to be ignored.
All right. Rajan. Rajan, are you there?
Yeah, I'm there.
There.
Yeah, again, a very tricky situation. The honesty of the communication is important to the main members. And always, as Dr. Jogarao said, have the same person there each time you're doing the communication. And tell the rest of them, so-and-so knows the full details. We have got our priorities in treating the patient. So briefly, you need to outline or have a story ready for the additional people that can come in. But all details and prognosis to go to that one important family member. So you kind of keep two stories with you, two ways of doing it for that particular patient, and bounce these extra people off to the main communicant that you have had in this treatment.
Yeah. Shivram, do you want to come in, please?
Yeah, thank you, Dr. Lakshman. I think I agree with all the panelists, and there is no single way of dealing with it. Nowadays, we ask the patient's relatives at the time of admission only, who is the representative person from their side. Every day we will be communicating to that person, and that is the responsibility of that person to communicate to the rest of the family. And whatever is there, our communication is one representative of the family of the patient. Yeah. I think that is the best way to deal with it, so that communication is continuous and the message is properly conveyed to the family through that person.
Perfect.
Thank you.
All right. Now, this is another very tricky thing that happens all the time. You know, medicine is an imprecise science. Risks involved cannot be quantified in a perfect way. Okay. So there is let us say there is a patient in the ICU who has poor chances of survival. The surgeon sees the patient and says, yeah, I think there's a less than 20% chance. The intensivist who is looking at him, a little later tells the family, oh, it's about 10%, and neither of them is wrong, neither of them is really correct, because nobody can really quantify what the risk is, but everybody expects a figure from you, and so in a very genuine but perhaps a little casual manner, the two different specialists give you two different quotes. And of course, that really gets the antenna up, and the family says, you guys don't know what you're doing. Number one, or you guys are dishonest, even though what you know what you're doing, the data that you give us is not believable. This is a problem that occurs fairly regularly. Dr. Guru Shantappa, how should we tackle this?
Sir, regarding this, for example, in our surgical practice, as a surgeon, I will be knowing what is the outcome of that particular patient after surgery. And if there are problems in the post-operative period, I'll be giving more importance to the cause of the poor outcome or the seriousness for which the patient is suffering from. I insist my intensivist or the caretaker or a physician who is in charge and my opinion regarding this, like what exactly the patient is suffering from, should not be any difference in this, rather than percentage of the survival rate or percentage of the chances of losing the patient. If there is a difference in what exactly is the patient is suffering from, if there is a difference between the two treating doctors, then definitely we'll be highlighting to the patient and the relatives that probably we don't know about the patient, what is going on. So I'll see to that, what exactly is going on with the patient. It should be uniform from all the team, whoever is attending the patient, not this percentage of survival or the poor outcomes.
All
So
right.
my importance will be for the disease or the problems, what the patient is suffering from.
Yeah. Now, there are two ways that I can think of dealing with it, and after I finish, perhaps the panel can come back and critique it. I think the first thing is that only one person, the leader of the team of doctors looking after the patient, must be communicating. Of course, the family will accost the other members of the treating doctor team and say, look, what do you think? But they must all say, look, we have, just like you earmark one person from the family with whom you communicate, you earmark one person in the doctor's treating team who does the communication. If it is impossible to do that, or if the family demands that they need to talk to more than one person, then it must be a joint effort from the 2 or 3 senior doctors looking after the team who sit together and have this communication session, and so that nobody contradicts the other, because they know within the team, it knows that there's no big difference between 10 and 20%. When they communicate, it is a number that they're trying to put. So they can sit together so that there is no differences in these little things, which is little for the doctor can be very big for the patient. Rajan, your comments on that.
Yeah, very important thing is these numbers and the predictions of the future. We ourselves, as I said, medicine is an incomplete,
Imprecise science.
inaccurate science. So we have to be a little careful and use the word every day as a bonus. Let us look at it as an opportunity to enjoy the company of so-and-so patient for this time. I've had the bad situation of opening my mouth and saying this is stage 4 carcinoma lung and he has about 6 months of life because you asked me. 2 years later, the wife came back to me and said, sir, he has not yet died. You have given me 2 years of torture expecting him to go away. So I did not know what to do. So I said, aren't you happy he's with you for 2 years? She said, no, but always on the tension that he's going to die anytime. So it is very difficult for us to predict the duration of life. That is not enough.
That's
but
true.
We can predict a quality of life for the next day, hopefully. A little more accurate, little more closer to what we are saying.
Yeah.
And say every day extra is a bonus, treat it as a advantage and have best use of the person's life and company.
Mrs. Murthy, would you be happy with, as a patient's representative, when doctors are not precise in terms of outcomes and things like that, would that be acceptable to you? Are you there, ma'am?
I lose my voice. Okay.
Yeah.
If you mean doctors means different doctors giving different precise numbers can be very confusing and also not very. I mean, that's the reaction that you have seen. But on the other hand, if one of the doctors says, I'm not going to tell you, you should ask only one doctor, that also frightens the patient. That means you have seen something, you're not willing to tell, you're letting somebody else do. So there is a real problem of different doctors saying and the group talking. So patients, so instead of using a 20%, I think the ability that yes, there is not to worry, things will happen. We think so. Qualitative statements are probably more acceptable to a patient or to me that time than a very quantitative 10%, 20%.
All right.
And of course, giving credit to the patient, like, you can do better.
Yeah, but ma'am, I can tell you that most people want some quantification. You know, if you talk about a complication rate, if I say it's a rare complication, tell me what percentage is something that is very commonly asked. So people do expect some kind of quantification. But as I said, this is a difficult problem. I don't know whether we have given the answer to our listeners. But yes, the point should go out that perhaps one person should do all the communication. If the patients, if you feel that the family is unhappy with that situation, it must be a joint exercise where people get together, discuss the case before they go, and the doctors, I mean, get together, discuss the case, and then go and jointly talk to the family. Now, one of the commonest things which I have faced myself, and I'm sure all of us are facing, is we keep talking to people, we talk a lot, all of it cannot be written down. I might write a single sentence saying that the risks and complications are involved have been discussed. Okay, that's what I actually do. I write it, the risks and complications involved, foreseen are discussed, and leave it at that. We will have talked about all the complications. You know, we talked about it last time, the common complications, the grave complications and all that. And 2 years down the line, you hear from the KMC or the Consumer Court, where one of the main things that the family says is that nothing was communicated to me. If I knew that obviously it will be a patient who has had a complication. If I knew that this complication would have occurred, I would never have undergone surgery. So have we reached a stage in our society, as a doctor it is very uncomfortable to me, where we have to get the patient's or the relative's signature on everything that we write. Right now we are writing risks and complications communicated and we sign. But do we have to get it countersigned by the patient or the relative? Or should we go on to an audio recording or even a video recording? There are many ICUs now routinely doing video recordings. Have we to make that a standard practice? I'll come to Dr. Jogarao last, but let's hear from Venkat about this.
Thank you, sir. The thing is, over the period of years, like you and I do, we have been writing each and every complication. Sometimes if we miss out, that consent form will be edited often. But most of the complications are always written. But as you told, there can be that patient may say, relative may say, we couldn't read English, we couldn't read Kannada, we can't write everything in their language. Many times we write a note in their own language.
So what's your view, Venkat? Sorry, be brief. Do you think we should go on to this or not? Should we get them should we get them to sign on the case sheets?
Yes.
Or should we get an audio recording or video on a regular basis?
Video recording will be the future, sir.
All right.
Right.
I mean, now would you start doing it tomorrow? After
we have been
this,
doing for few cases, which are very high risk cases. We have been doing that.
Okay.
But it may come up for every case.
Yeah. Dr. Guru Shantappa?
Sir, I don't know. Probably future will be video recording. But at present, the first one, I sincerely follow that, and I make my even students to follow that. And in private, definitely I do write myself in the case sheet about what are the probable complications I'm expecting in this particular patient.
You list out the complications and problems.
Definitely, sir. Definitely, sir. And in the consultation itself, I tell them, even though I say it is a 90% everything will be fine, I'll tell in Kannada that yes, your patient, I'll come to know whether it comes into 10 or 90 only after surgery. Only after surgery. What is 90? It is 100% for them.
For them.
What is 10 for me? Yeah, 10 it is 100% for them. Yeah. So I'll make them understand.
All right, fair enough. Dr. Jogarao, your comments.
in my opinion, the informed consent, what you procure before conducting surgery, is to be distinguished from while you communicate bad news. Therefore, these 3 points are to be responded to in that context. In my opinion, there is no legal mandate stating that any of these 3 are to be followed. If at all certain centers are following, I think considering the medical litigation environment and maybe as a matter of abundant precaution.
All right. So when, okay, I take your point that, informed consent is something. Later on, let us say the patient develops a complication of surgery, okay, and on day 3 or day 4 of surgery, it happens sometimes. So we go to the patient and say, and then the relatives and say, look, this has happened, this is the kind of outlook, these are the problems that we face. Okay, should that then be, we write it in the case sheet, but should that be countersigned by the family?
Not necessary.
Not necessary. So in the legal parlance, at the moment, we haven't reached this stage yet, but as a way of abundant precaution, the choice is left to us. We may request the family to sign or leave it as it is. We switch gears now and go to the next. Go on. Sorry, somebody wanted to say something?
Yes, I wanted to say.
Please, yeah.
This is, if you ask them to sign, I've seen this in the research studies where respondents are afraid to sign because they probably think that you will be doing something by, if I sign something,
right,
then I'm absolving you of any responsibility.
Right. That is the real problem. That's why we don't keep asking, because it also erodes trust. A lot of medicine even today goes on trust, but that is a trust that can sometimes misfire and can be very costly. But to be honest, it's not a large number where we face this problem. And so perhaps we go by gut feeling and say whether, look, these people are, if they are very aggressive in the way they approach you, then perhaps in those people you may select those families to put a signature, so to know that we have done what we have to do, in terms of communication. But that is still subjective and it is left to the person concerned. Now, we really need to know a little more about advance directive, living will and things like this. Very common and very natural in the Western population. We were aware of it 30 years ago when we were in the West, 35 years ago. Still very alien to the Indian population. The average Indian family, when you talk about death, it is an apashakuna. It is a bad thing. Don't talk about death. Why are you saying this? But in advance directive, you are doing exactly that. You are telling your views about what should happen after you pass on, or you are in the process of passing on with a disease or disability, where when you cannot communicate in real time, you would want something done. Now, I would like the panel and some of the audience to articulate what they think about it. Rajan, what do you think about advance directive? Should we have it? Should we not have it? Should we make it? Should we sort of make public aware of it? How should we go?
Also varies with the educational level and the equality of communication between the patient and the doctor and the surrounding situation. There are some people who have no idea of this, and I think asking them to do that is not the right thing because they don't know what they are doing and saying. Whereas if you have educated people who are coming to you in an environment where they understand these things, after the bad news is communicated, two things I tell them. Please see that you settle your accounts and your other financial important things fairly soon, because there seems to be a shortening of your lifespan. And we would also like to know what you would like to be done to you if the things go in an adverse direction. Put it to the patient. And once the patient understands, they give you some directives which then you can be comfortable implementing. Right. So I feel it varies with the educational level of the patient.
All right. Should we undertake a public information or public education campaign about this? Is it a responsibility of, say, a surgical society to do that?
I would say yes.
Okay. Professor Elgachin, Guru Shantappa sir?
Yeah, really, sir. It depends on how much they can understand, how much they are aware of it exactly. It cannot be uniform to every patient with difficult outcomes.
Right, right. Mrs. Murthy?
Yes, I think it's time that people get educated so that what it means and so getting preparation for that. It
All right.
will take time.
Dr. Jogarao?
As matters stand, the Honorable Supreme Court's judgment pronounced in the year 2018 is the law which governs advance directives in this country. Terminological clarification at the outset. Advance directive, living will, healthcare directive, they mean one and the same. In different jurisdictions, they are called differently. As far as Indian Supreme Court decision is concerned, it is in advance directive. According to Supreme Court, it is valid, legal, and it is a matter of fundamental right of an individual. What exactly is that? It is a written instrument executed by a competent person, clearly mentioning in the event of a particular situation, the treatment may have to be withdrawn or the person shall not be subjected to any invasive procedures, etc. Something like DNR and DNI. That is where the law as matters.
Yeah, thank you. That's a very clear statement. And here we go. As Jogarao said, this is a legal document. It is a person's wishes about receiving medical care and what degree of medical care. And it may also empower another person whom the individual, the patient chooses to take such medical decisions. These are the three things. Now, one of the confusions that I have is that in the West it is very clear. It has to be a notarized document that is done, and there's a process for it and many people do it. Here, what is the legal requirement for a patient to be placed before a doctor to say that that is his advance directive? Jogarao sir.
Yeah. In our context, as laid down by Honorable Supreme Court, which significantly varies from other jurisdictions, including Western. When once a document is done, please remember, simply notarizing the document does not make it as a legal document. There is a procedural formality towards that. That formality is indicative of that in the presence of two attesting witnesses, the document must be countersigned by judicial magistrate of first class. And secondly, when once witnesses and etc. record their satisfaction that the directive has been voluntarily executed by the person concerned, then the copies to judicial magistrate first class, registrar, municipality, authorities, etc., etc. And if the family members are not present at that time, the magistrate has to inform the other family members also.
No.
This is only one part of it. Suppose I execute such a directive and it is properly in the custody of a particular department, and I encounter a situation where I am in a vegetative state. In such a case, how do you really execute the directive that is the part 2? That is something a very important legal procedure. For example, the hospital where I am being treated, the hospital, when once they get to know that Jogarao has executed advance directive, the hospital has to constitute a medical board. The medical board will look into the condition, etc., 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 and they inform the jurisdictional district collector, and district collector constitutes another medical board, and that medical board will look into, and they will decide whether to go ahead with the directive voluntarily executed by Jogarao or not. They may say no. In such a case, we have to go to the High Court. They may say yes. Then the kind of thing.
Oh.
I think the procedure,
highly complicated.
Western jurisdiction, here it is. But I must add one sentence. What essentially the Supreme Court was concerned is whether it will be misused. Therefore, they wanted to have this kind of safeguards. That's all.
It's really very complicated and very difficult to really execute, I believe, because it should be made simpler. And I'm told that there is no, in the absence of a legislation, even the courts are trying to find some kind of reasonable path to take in our country. As Jogarao rightly pointed out, we use the word advance directive for all these things, but then it actually consists of a living will. There are subtle differences, but as it doesn't apply to our country, I'm not going into those differences. It could be a durable power of attorney where you authorize somebody else to take decisions on your behalf, or it could be a DNR order. The problem in my reading about this in our journals is that we do not have statutes or Supreme Court directives which honestly, in a way helps you to carry out this part of our constitution. I'm told the Article 21 of our constitution gives every person the right to die with dignity. But all the authorities, the ethicists and the legal authorities who have written about it in our country say that it is actually not being done. I'm told, and perhaps Jogarao could correct me, I'm told that there is a legislation on the anvil, on the boards, and people who have read the draft of that legislation are unhappy because it doesn't address the question adequately. Is that true?
In fact, this particular legislative bill was before Honorable Supreme Court's judgment.
Okay.
And there is a tremendous consensus that the content doesn't really reflect the need of the hour.
Okay.
In a way, Supreme Court judgment has clarified that. But
all right.
It is only a decision now. We don't have legislation.
Yeah.
And even the decision also requires, in my opinion, review so that a simple procedure is put in place.
Yeah. So, as was clarified, as of today, if a doctor or a hospital has to be covered for, not treating or whatever, withholding treatment or things like that, you really need a permission from the courts. All right. Now, we go into situation in the absence of an advance directive. We get into difficult situations clinically, and I'm going to go through 2 or 3 such scenarios. Elderly lady, widespread cancer again. The son wants only palliative care. He understands, the patient understands, she doesn't want to go through any invasive procedure. But there are certain other members of the family who disagree with their sibling and say, I want everything done. It's my mother. Where does the doctor stand here? Rajan.
Very difficult. I've had this situation more than once and in fact got into trouble about it because I believe in quality of life, not quantity and extension of life at any cost. So we need to counsel those 2 daughters on what you want everything in life. Are you expecting cure? Are you expecting that to be back to being normal? And tell them there that is not being medically, it is not likely to happen. And we should look after the quality of life that the patient has and enjoy her company for the remaining days. So the counseling shifts from the son to the 2 daughters who are not willing to accept the situation. It is an emotional outburst, and after a few days, they too come around. So we just have to buy time and talk to them and convince them.
All right. Mrs. Murthy?
I fully agree with Dr. Rajan. I face similar situations. And probably if they suspect that brother doesn't want to spend money or is in the financial consideration, then it makes it a little more complication. But explaining to them who the daughters is, to my mind, is the way to go.
All right. I'm digressing a little bit because I'm taking a question from the chat box. There is a situation where the patient cannot take a decision because of the disease process. The son, that is an immediate relative, perhaps the legal heir, if you want to call it that, is in denial. He doesn't understand and doesn't want to take a decision, and what needs to be done can potentially harm the patient. In that situation, can the doctor talk to the next circle, maybe the patient's brother, maybe the patient's nephew, and then see if a proper decision can be taken. Is that legally allowed, Jogarao?
In fact, this is something I just make a mention. Earlier, when you asked a question about whether this particular area requires to be disseminated to public, etc., even Dr. Rajan said, yes, there is. I think there is a tremendous need through SSB, in my opinion, because there is a second part of the judgment which deals with the situation which you are referring. Suppose the patient doesn't execute advance directive, but he is in such a situation. Supreme Court judgment, the same procedure needs to be followed.
Right.
That is the law as matters stand.
Yeah.
And many of us, we do not know. I think that's where the dissemination, etc.
All right. Okay. Let's go to a slightly different view. Okay. It is a chronic asthma. It's not a fatal disease, but nevertheless, ventilation is required to get the patient to some reasonable state. Note that this is not an end-of-life situation. Patient has a chance of getting better. 2 of the 3 children insist that their mother never wanted ICU or ventilation and wanted to die peacefully at home. The 3rd son cannot be contacted. There is another sibling, he can't even be reached for whatever reason. So we don't know what his status is. Can we go with the 2 people, two children whom we have seen, and then say and not put the patient on the ventilator, respecting her sentiments? Are we justified in saying I am respecting the patient's autonomy? She has clearly said that she doesn't want any treatment. I am going to listen to the 2 people who are here. Or if we do that, are we exposing ourselves to risk from the uncontactable 3rd person in the family who may come and blast us later? Guru Shantappa sir.
Sir, really sometimes this is a tricky situation where definitely they may come in the way of our planned treatment. But if I feel definitely my plan of treatment in the form of ventilating is going to help the patient, which most of us will be knowing as a treating consultant, definitely I'll try to convince whoever is available, like you have given 2 children, I'll try to convince them. If it is not possible, the surrounding, like in the previous scenario you said, the next relatives who are available around them, I'll speak to them so that they can try to speak to them and convince them. But if I feel it is not going to help the patient, I'll respect their decision. So it will be ultimately my decision pertaining to that particular scenario and the outcome, which we will be knowing as a medical person. Depending on that, I'll put the efforts to convince the people.
All right. Puneet, what do you have to say? We'll reach some younger colleagues and see what they have to say. Puneet, can you unmute yourself? All right. Maybe he's not there. Rohit, can you come in, please?
Yes, sir.
Yeah. What do you think? You saw the scenario. What would you do in this kind of situation?
At any point of time, it's a difficult situation to be in, sir, actually, to be very frank.
Yeah.
But,
I mean, most
yeah.
situations we have, but we are willy-nilly, we are involved in such situations. That's why we're trying to have a discussion. Yeah, please go ahead. Yeah.
So I would actually legally document with whoever is there at that point of time.
Okay.
Communicate whatever is at that point of time is feasible to do rightfully for the patient, keeping in consideration how she might progress for next at least 24 hours. That is the time I would at least need for the patient attenders to understand that by this time we can take absolutely what is to be done or not to be done. If you want to withdraw support, at least that much time you need a space, that breathing space for them to understand.
Well,
so
there is, yeah. Okay.
So if
so you're going to buy time and see what you have to do if you can.
Yes, sir. Yes, sir.
All right.
Yes, sir. That's
Fair
absolutely.
enough. All right.
Yes,
all right. Okay. Now we come to the last part, and hopefully we'll finish it in reasonable time. What is your thinking on end of life care? Let us first see what we all think about what end of life care is. What is end of life? Because we all said that it's very unpredictable. Rajan made the point. It's very unpredictable as to when somebody dies, even if they have advanced disease of one kind or the other. So when there is no clarity on the end of life, how can we get clarity on end of life care, as it were? So what is one's definition of end of life care? Rajan?
The quality of life goes when a person's not able to look after themselves. A certain amount of self-care and need to be done, like feeding, excretions and other things, have to be in the control of the individual, along with the certain mental capacity. When you know there is a definite diagnosis of, say, a malignancy, we need to understand that the days are getting numbered and they have to move to palliative care or hospice care, where this end of life situations are looked after and patient is nursed into the, with the dignity, into the death time. So end of life care should not be abused. It should be very critically evaluated and see what quality that person is having. You may have a young person who's got an advanced malignancy. Being young, you want to keep him going forever, but does he have quality of life? So you need to introduce end of life care concept.
At that point in time. Okay, so you think you're measuring the quality of life. Yeah. I'll just go back to the previous discussion, because there are two questions in the chat box. One of them says, one suggestion was that you buy time and see what you can do. It is an emergency. You can't buy time. You have to put the patient on ventilator. There is a controversy in the family. What should be done? Rajan.
Again, little difficult to actually come up, but you have to explain to them, and then if they insist that the patient, this is about discharge, right? You're asking?
No, this is about ventilation. You think ventilation will help, but the family thinks it doesn't help.
Yeah. So then you have to explain that they are
You
wrong.
will put the patient on a ventilator.
Yeah, I will go ahead and tell them medically I am not justified in withdrawing ventilation, because I know ventilation will help the situation.
All right.
It's not a no situation, which you have understood it to be. There are good chances of.
Yeah, that is the asthma patient I mentioned about. Suppose it's a terminally ill patient with cancer. What would be your answer?
Then, like a patient's advance directive, this is the relative's advance directive.
Advance directive, so you would not put the patient. So there is another variation on the same theme. Dr. Srinivas asks, what if the family actually asks for discharge of the patient? Would you discharge the patient?
Yes.
And write and say, discharged at the family's request.
Yeah, it's not against advice, but at request.
At request. Jogarao, is that legally safe to do? The two things, not putting the patient on a ventilator or discharging at the relative's request.
In the earlier, that particular case scenario, that 60-year-old lady, there is one part of the sentence, I think that requires to be addressed. That is, mother wanted to die peacefully at home.
Yeah.
That does not mean whatever the condition would lead to that kind of consequence. Therefore, it is the clinical doctor's decision that is paramount.
Okay. So it is.
Yes. Ventilator. If the doctor is of the opinion, irrespective of what the patient would have felt or even doctors are thinking, if the condition according to the doctor is going to improve, I think it can.
Yeah.
And in terms of the other also, I think if end of life care, that's where futility of treatment.
Yes, that comes up. So that answers, it depends on the clinical estimate. If it's going to improve the patient, you would not withhold the treatment of ventilation also. If it's not going to improve the patient, yes, you can safely either not put the patient on the ventilator or discharge the patient and document that it is done at the request of the family. Okay, so just to just to expand on what Rajan has said, care given to people who are near the end of life and have stopped treatment to cure or control their disease. This is the one. You reach a stage when you know as a doctor you can neither cure nor control the disease. It includes physical, emotional, social and spiritual support. and the goal at that point is to control pain and other symptoms. Treatment is only to, the treatment is only to control symptoms, and it has several components, which is palliative care, supportive care, and hospice care. Jogarao mentioned about futile treatment. Mrs. Murthy, would you agree that there is something called futile treatment? What do you think it is, and what are its consequences?
Unmute.
Unmute, ma'am.
Futile treatment, I think I had never thought about it before, but is something that doctor, the hospital knows is not going to help, but believes that we have to do the most as much treatment as possible, because there is a small chance of 5%, but at the end of it, it doesn't result in. But I'm really not sure.
Okay, fair enough. That is the standard. Very few people even know that something called futile treatment exists. Forget about our patients, not even many doctors would subscribe to that. And if people believe it exists, what is its definition is something that is debatable, and that's why the point came here. Guru Shantappa sir, what's your take on this, please?
Yeah, definitely I do agree, but I may put it in a different way to the patient. In spite of my best knowledge about the disease and the outcomes, whatever the treatment I'll be giving for that particular patient, probably it may not help in all the ways. The percentage of helping of different symptomatology or the outcome of the disease, it is so and so, so and so. So once they say yes, I'll implement. Once they say no, even for that also we are reluctant, then I'll stop that, instead of labeling that treatment as the futile treatment.
So basically you will go with what the patient or the relatives say.
Yeah, with my explanation, knowing what are the outcomes of the treatment, knowing very well what are the outcomes.
Shivram, do you want to come in and take that? Your views, please. Okay, Venkat?
Yes, sir.
Futile treatment, do you believe in it? If so, what do you think it is? And see, what are its consequences? Yeah.
There should be benefit of the treatment. The patient must get reasonable palliation. Quality of life ultimately comes into picture. If it is not going to get benefited in either way, then there is no point in putting effort and at the cost of suffering and the expenses also.
All right. Okay. So this is very much a known entity in medicine. As Rajan said long ago, and I agree with him, I am a great believer in this. Quality of life is a lot more important than quantity. So a futile medical intervention is ineffective and serves no meaningful purpose, no matter how often repeated. So it is not palliation. We're talking about treatment. And how do you define it? That is where the problem is. If it has not helped in even 1% of cases, Mrs. Murthy mentioned 5%, and I would mention 20%. Honestly, if it doesn't help a large number of people, there's no point in doing it. And that is debatable. People may not agree with me on this. And when it comes to treating my patients, I give it to the patients and the relatives. They can choose what they think is useful, outcome. It merely preserves, permanent unconsciousness. This is the vegetative state, as it were. You're alive, but you know nothing that's happening around you. And it only preserves organ function without advancing health as a whole, which is a situation seen on people in ICUs with, triple inotropes and things like that, and big time antibiotics and things like that. You know that they don't come out of it. This is futile treatment. And it is not as simple as one can, think of in terms of present day care. And that is because the concept of autonomy has taken away the decision making. While we keep talking that the doctor knows best, it is really not generally accepted in society. That is the reality that we all have to accept with equanimity. And because if you say I know best, you will probably be accused of paternalism. So that is where the conflict comes. And without doubt, in my mind, I'm sure in most of our minds, autonomy wins. And so we come to the conflict, and this is what we are trying to try and see if we can get some clarity on this issue. Patient in sound mind with collagen disease, which gives him very painful arthritis and renal failure, he does not want dialysis. He is very clear. Remember, this is not a fatal disease in the sense that with dialysis they can last many years even, but it is very painful and he doesn't want dialysis. The family wants it, everything that's necessary to save him. Okay, what do we do in this situation? Here we are only functioning, preserving an organ function, which is the kidney, but he has to continue to live with his painful arthritis. You may give him painkillers and this, but it is a very difficult situation. Rajan.
The key word is sound mind.
Yeah.
He is of sound mind. We have to respect his decision.
Right.
And though we will go out of the way to explain the advantages of dialysis and other things, he has suffered his painful arthritis. Now this moves into a very gray area of quality of life in a young person. So if his mind is sound and he has asked for it, document it and we'll have to follow it.
No, but if you remember, Jogarao said that if you have to withhold treatment or do something like that, there is a process.
Yes,
You've got to get all that done. Without doing that process, would you not undertake dialysis? But if you don't take it, and if the family goes to court and said that the doctor has done something which is unacceptable, how do we face it?
Again, the proper counseling and the consent that has been taken as a form of directive from the patient,
Yeah.
will be holding us in court. The Professor Jogarao, is that correct what I am saying?
Yeah, that's Jogarao. Can you say that if the patient gives in writing that he doesn't want dialysis, can I quote autonomy and say, look, I'm not doing the dialysis because I don't have the patient's consent?
I just want to clarify one point just now you mentioned. In terms of Supreme Court judgment, with regard to executing advance directive, etc., we are referring to a person who is incompetent at that point of time. But here this man is a 40-year-old, sound mind, and he doesn't want, and he is alive, and he will be alive. The only thing is he doesn't want to face the pain, etc. In my opinion, a person is entitled to refuse treatment. Whether he or she is going to die or that is a different matter.
Yeah.
But right to refuse treatment is entitled, and as Dr. Rajan said, with detailed consent, etc., it can be.
Yeah, that was the point I was trying to make. Even if it is a completely salvageable situation with dialysis or whatever, in a young person, autonomy rules the roost. That is the message I think that we should all take here. Again, elderly gentlemen, I'm giving you different scenarios because we face this. Young person, it's one decision. In an elderly person, he is in sound mind. There is no, and it is not something like a collagen disease, but a widespread cancer. Refuses to eat food. He doesn't want to live. He has no interest. Okay, and the family says, look, how can I not do something as fundamental as giving food to my father? You have to put a tube down and feed him. Should the doctor force a feeding tube down his gullet and feed him? Ravi Shankar, what would you say?
Again, I think it's a very difficult situation. What we can do is to try and explain to the patient is to understand why he is reluctant to have something done.
Yeah.
It's not an extremely invasive procedure. The thing is to try and explain and say that we will not feed you all the time. We will use it maybe to give you some painkillers. And
He still refuses. After your best efforts.
Then I think we should, because he's of sound mind, we should respect his views and explain to the
not
family,
feed.
And explain to the family that we have tried our best to explain. The patient is still very clear about not needing a tube, but not wanting a tube.
Yeah.
I will not do that.
Yeah, very nicely I talked to the family, myself in this situation, has happened many times, and said, look, you have to convince him. We believe in autonomy. He has a right over his body, and I can't force my views on that. And I think Jogarov has clarified that autonomy really works in these situations. Now, this is another slight variation of this which I am looking at. This is about tailoring different periods, different kinds of treatment. You know, the family says, the patient is very clear, he wants to just go home and have nothing done. But the family wants to initiate feeding, give a blood transfusion if he is anemic, give him nasal oxygen if he drops his oxygenation, but it does not want dialysis and ventilation. In other words, the family is trying to tell you what you should do and what you should not do. That is not in keeping with what the patient wants. The patient wants to go home and die. What should the doctor do? It's a variation. These variations occur, and I just wanted to be clear. That's why I brought these scenarios in. Mrs. Murthy, what do you think, ma'am? If this happens, what should the doctor do?
Does doctor want to give up all his autonomy to decide what is good for patient? Ask family decides what it should go.
Ma'am, society is going that way. If today doctor says, look, I think this is the best for you. I'm not saying every patient, but a good number of patients are saying, look, I'm sorry, I have the autonomy, I decide. And the doctor is, you've seen several scenarios in this situation where there is no consensus in the family also. If there is a consensus between the patient and the family or the different members of the family, we wouldn't have this discussion.
Doctor's office cannot be a family court where everybody is deciding and discussing what to do with the patient. About this particular case, and first of all, you say sound mind. I don't know how does one decide a sound mind.
Yeah.
But there is a possibility that a person says, a young person that we are talking about, if he
this one is an elderly gentleman, ma'am. Yeah.
This is elderly gentleman. Yeah. And he wants to go home and die peacefully. I think there I would agree that his decision should be accepted. The family doesn't have to be, as long as you can prove that it's a sound mind that is being.
So, Jogaro, is it right for me as a doctor to say, look, I cannot be doing this or doing that and different things at your instruction? You either leave it to me to treat the way I want to treat him, and of course, if he says he wants to go home, I'm going to allow him to go home. Is the doctor right to say that, ethically and legally?
Yeah. Doctor, I thought I'll just respond to what Mrs. Murthy said just now. I think that's a very important point. She says, no, you have written in both the case studies, sound mind. I think that is a fact is to be established beyond doubt. I think that is fundamental, even for a doctor to come to a certain conclusions. Now, with regard to the kind of decision, for example, doctor to initiate feeding, to give blood transfusion, that's what has been mentioned. Supreme Court mentioned very clearly, forced feeding is violation of a person's right to privacy. If the doctor thinks that the individual in a sound mind has taken a decision, and if it is established clearly, I think you can go ahead and whatever, whether he wants to leave or leave at medical advice, etc.
Yeah. I sort of dilated on these little variations because I wanted our audience to be very clear that all of these things can be done, because generally even the law thinks that the autonomy is supreme. When there is a conflict, all right, we all talked about what do we do. We said we talk to people. One of the things that we can do is get a time limited trial. That is something most families seem to understand. So if they want to try something, and you say, well, okay, you want to try ventilation, don't try ventilation forever. Try it for 3 days. So it's almost a negotiation where the doctor says, I think it's a good thing to do. The family says, I don't want it done. I said, look, why don't we try it for 3 to 4 days and then see what happens. And most people generally seem to accept that is one way to go. And when it comes to the, as you said, Mrs. Murthy made a very good point that the doctor's chamber is not a family court, where you sit in judgment. But then one of the things that you can do is do this. My apologies for the disturbance. One of the things you can do is actually do the job of a judge, if you like, but not with everybody together, but with the patient, because patient is supreme, autonomy is supreme. And you can do this, it goes by the mnemonic nurse, which says, name it, try to define what the problem is, understand the core message, respect him that his autonomy will not be violated, and try to support that communication in the family by saying, would you like me to talk to your family about this, so that an independent person is doing it, and in the end explore or address the patient's concern. That is a part of empathy, and then try to see if you can resolve the situation. These are things which are easily said but may not be done with ease, but it is something that doctors can try. And I come to this cost of futile treatment. Please note, I am not going to open up a big discussion because of lack of time, but there is enough and more evidence that futile treatment is extremely expensive. Even in affluent countries, you can see that an enormous amount of time and effort is spent. It is about 12% in one Australian study. It is 20% in futile treatment in one of the American studies. A lot of money is spent on it. It is said that 80% of the healthcare cost is spent on 20% of patients. Gross discrepancy in the amount of money spent, and huge savings can be made if you do not undertake futile treatment. More important thing, when you are having futile treatment and you have patients on ventilators who perhaps it's considered futile, then there are many patients, you can see here, a good number of patients who actually need it do not get it. That is something we must understand. That is something society has to take into consideration. And when there isn't much of insurance cover as in our country, I have seen families go into penury with their patients on ventilators. You spend 15-20 days, the bill runs into lakhs of rupees, and they actually sell their property, their lands, their house and this and that, and then at the end of 20-25 days the patient also doesn't survive, and they really are nowhere. And that is something that all of us have to think. No easy solutions, but that is something we need to talk about. And final part of our discussion, what is palliation and how do we look at hospice? When we do this, I'll again run through, again I'm talking about sound mind because that is fundamental, as Joga Rao said, and we have ways of knowing whether somebody is in sound mind or not. I won't get into it. Again, the family is unable to give the necessary support. They have no doubt that there must be palliation. Okay? The doctor recommends palliation at a hospice. This actually happened to me, and that's why I'm trying to put this up. The family is very angry because they didn't know the concept of a hospice. And they said, look, you are the doctor, you looked after him when he had the cancer, you treated him some time ago, and now that he has reached this stage, you are absolving yourself of the responsibility of treating him. That was the impression that they had when I suggested a hospice. Now, how do we approach this problem? Guru Shantappa sir.
Yeah, if we are involved in the initial part of the treatment, it is very difficult to convince them for a hospice treatment for such patients, really. If we are not involved in the initial phase of our treatment, definitely it is easy for us. But if the patient is insisting that, yes, he wants to be at home, we can try convincing these patient relatives. Otherwise, it is a difficult scenario to convince them for the treatment, like hospice treatment, sir.
Right. Okay. Yes, it is a very difficult situation. That's why I brought it across. There are no easy solutions. You can then try and get them home hospice care. Even that is available. Instead of sending them to a hospice, we can perhaps get them home hospice care. This is another very tragic situation that we face. Hospice care and palliative care is essentially symptomatic treatment, as we said. They are given very good painkillers given by these specialists, morphine tablets, syrups and tinctures and things like that, which keeps them very comfortable. But in comes a situation where one of the family members says, look, I have heard that in this stage naturopathy cures the patient. And the first thing they do is to stop all these analgesics. In other words, the palliation is out of the window, and the patient basically begs the doctor for the medication. You're still the doctor, he's sort of flitting between you and the naturopathy center, and he says, "Doc, I'm terribly in pain, I was okay last 2 months, now I'm in terrible pain." Well, how should the doctor respond? Rajan?
I think again it is the patient's will and patient's life and our need to alleviate pain. If we cannot extend life, at least we can control pain.
Yeah.
Pain is an important element, and you must tell them that the naturopathy has no known scientific reason to be useful in this pain treatment.
Yeah.
This is the scientific reason along the whole world. So kindly allow the patient to be free of pain, to put it into their place. If your treatment is not effective, isn't your patient going to suffer more?
Yeah.
So you put it like that, and then they will somehow allow you to continue the morphine.
Yeah. In fact, in this particular case, I can share that this person was still insisting on naturopathy, but I was lucky enough to convince 2 of his siblings, the 2 other children of this patient, to say, look, he is suffering and it's obvious. So they quickly went back to the morphine tablets, and the patient had, fortunately, a reasonable end. This is another thing that has nothing to do with ethics. It has nothing to do with what you do, but I wanted my colleagues to know what the situation is. There was a lady with very advanced cancer who had a perforated bowel, and people didn't know much that there was an advanced cancer. They went in and did whatever they had to do. I won't go into the technical details, but then they wanted a laparostomy. Laparostomy, for the non-doctors in the group, is to say that you have chosen, because of excessive amount of infection that was there, you have chosen not to close the abdomen. Instead, you put some packs, as we call it, and then you will probably go in again in 24 or 48 hours and clean up the abdomen again, because you know that you are going back in. You do not close the abdomen. But as can be expected, the patient died before the re-exploration could be done. But at that point in time, the patient was accused of negligence because of leaving mops in the abdomen, in spite of telling them and in written notes that this was a laparostomy, and explaining to the family in layperson's terms what the laparostomy was. The patient didn't go to court or anything, but there was a very unhappy kind of situation. Rajan, is there anything else that could have been done?
The first thing is, as soon as the patient died, that abdomen should have been opened and mops taken out and abdomen closed before you declared death.
Right.
Death has occurred medically in the ward. You take out those mops and put on simple skin sutures, and then don't mention anything further.
Right.
Okay. If you tell them that the mops are inside and they go to XYZ place and or whatever, the mop doesn't somehow survives, and they find out that there was something, you are asking for trouble.
Yeah.
So when you declare death, make sure that you have covered all the possible issues and correct them before you declare the death.
Would you agree, Dr. Gurushantappa?
Sir, probably in this scenario, I would have not attempted operating on these patients, because already it is advanced cancer.
No,
probably
the real situation was the surgeon didn't know about the advanced cancer. It came as an emergency, and they
then what Dr. Rajan said, probably that is a way it can be tackled.
All right, so we come to the very last slide, and I just need my panel's opinion on this. We all know that palliation and hospice care is not just giving painkillers. There's a lot to it. It's teamwork. There are specialized hospice nurses and hospice centers. They give a lot of these help, and that is something that we need to make popular among the lay public, so that they use it and make sure that there is real comfort at home for a patient in an end of life situation. But there is still debate about what should be done in a hospice. What is it that we can withhold? Mind you, this is not treatment. We know that this is to keep the patient comfortable. And what is it that we should actually do? Okay, so there is, I think, very little debate about the fact that you don't use ventilation, you don't use drugs to improve somebody's blood pressure, you do not use antibiotics, you do not use dialysis, and you do not give a blood transfusion. But the debate comes further down. If the patient is not expressly against a tube feeding, should we put a tube down and feed the person? We discussed situations where he didn't want it, but here he is not against it. Should we do it? Rajan?
Yes. See, these
Sure.
are all essential activities, just like your breathing. Should we stop the breathing because he's there? No.
Yeah.
You need to have nutrition. You need
Yeah.
to have basic nutrition, not advanced, not giving supplements and other things.
Right.
Make sure the hydration and the nutrition is okay.
Yeah.
And oxygen support is an external form of help,
Right.
so that the quality of life gets better.
Right.
So when you don't have nutrition, your pain is more, you're dragging your life in poor quality. So you have to balance it. I would
All
say
right.
nutrition, fluids, and oxygen, yes,
Yeah.
should be given. The other things, no.
So would you give IV fluids, Dr. Guru Shantappa, in a patient who is in a hospice and who is unable to drink and...
If the team, what is available in that particular area, can manage with a simple IV fluids, definitely
Yeah,
yes.
you would
But
do
if
it.
you feel they are not capable of managing that, you
All
will
right.
be inviting the problems.
All right. If the patient is gasping, all right, you know he is terminally ill, is in hospice care, he is gasping. I know that nobody questions the fact that you suck out the throat and keep him comfortable so that he doesn't aspirate. Keep him as comfortable. But would you give oxygen, supplemental oxygen?
Definitely yes, sir.
Yes,
Definitely
yes.
yes. Rajan.
Definitely yes.
Yes, but you know, I would actually go with what you have said, but the literature, if you look at it, has put a question mark on this. They say you can give oral or tube fluids, but not IV fluids. Oxygen, surprisingly, most people in hospices don't give oxygen, at least in the West. That is the literature that's written most. They don't give oxygen because they say that what are you trying to do? He's going to die anyway. He's very quickly going to lapse into a hypoxic coma, and they actually don't recommend that. But yes, I agree with you, in our situation, if it can be managed, that these things would be done. Can I now invite Dr. Srinivas, please, to give his final comments before we close the session? DK sir?
Yeah, thank you for this very interesting and a difficult situation where there are no yes or no answers. I did face a similar situation regarding my father, and those days was in 1984, so the treatment was not so sophisticated. They used to put a oxygen tube in the nose, nasal oxygen, and the hospital medical superintendent asked me, "Sir, we are short of oxygen. There is a youngster who needs oxygen. What would you say?" I said, "Please remove. My father has lived. We have 3 sons. We are all settled down, and of course, since I'm a doctor and I know who requires more care, and I said, yes, please remove." And of course, there was no conflict at home. And this is a situation. The second situation I want to know that although you said about the cost and that, can a doctor impose treatment on me when I and my wife agree, and then I don't want to be in ICU or I don't want to be put in an ICU because I've lived enough, so to say. Can Jogarao said, "Look, doctor, can doctor impose me?" Or when I and my wife agree to what we say? That is my question. Can you impose treatment on me?
Sir, before Jogarao comes, let me clarify. The point is, there are 2 things. If you have not specified what you want done with an advance directive, which the doctor doesn't know about, and you are not able to communicate at that time, all right, and your wife just verbally tells us that you didn't want anything done about it. So all the discussion centered around that fact. If there is just your wife who says there is no conflict in the family, as it were, if you say I don't want anything, we wouldn't bother about it. But if you had 3 sons, one of them would say, I want my dad to go on a ventilator, and 2 others say, I don't want him to go on a ventilator. That is where the the problem comes for the doctor, and that's where all these discussions took place. So in a straightforward situation like you say, where you know you can make the decision and your wife agrees with you, there is no conflict. Jogarov, your closing statements.
No, one second. Yeah. I raise this because what Dr. Jogarov described is a very difficult situation. You know, you go to magistrate and it's there and all that. So I will write down beforehand. My wife also signs on that. My children sign on that. So that is all. So this is, I'm saying this because patient autonomy. Don't have the right to die myself? The patient autonomy. That's why I raised this question. Dr. Jogarov, please, because it's a very difficult situation. The Supreme Court has said, okay, you can't go to magistrate, you can't get all those things, and so this is why I am asking.
Sure, doctor. I think very important question. I just want to tell you, the judgment what it has pronounced, very difficult, in a way, difficult means they have provided. That requires to be reviewed. I think the time is not too far. It's going to be reviewed, and accordingly, a simple processes may be put in place. That's what I would say.
Thank you, sir. That is the point.
Lastly, yeah. I know of two senior doctors. I don't want to name, but maybe you will guess when I say. One was a well-known nephrologist. He had told beforehand he used to do a lot of dialysis, and he knew what he could get. So he had mentioned that, look, I don't want ICU. And the doctors respected. Similarly, another surgeon, well-known surgeon, he also had told beforehand that in any case, I should not be admitted to ICU. I have lived with it. And the doctor respected. The only worry is if there is a conflict and if there is a legal, question, all this arises. Otherwise, by ways of what empathy Rajan said, through empathy and all that, I think that autonomy has to be respected.
Right. Sir, point well taken, sir. Yeah. Thank you very much. One interesting note is, the situation where you talked about two doctors, there is a survey which said that 80% of doctors who are presently carrying out certain things in an end-of-life situation would not want it done for themselves. They're doing it because of the tricky medico-legal situation and the pressures that come on them from the patient's family. That is the absolute
truth.
Only
that, not only that, Hippocratic oath. So they have to do their dharma. They have to do their duty.
Yeah. Okay. Thank you. On that note, I would like to thank SSB for giving us this opportunity. I would like to thank every member of the panel and the audience for such a nice and vibrant discussion. Thank you very much, and I hope that this will reach more people and that they will think about it, and society as a whole benefits from this exercise. Thank you very much, and good night.
Good night, and thank you.
Good night. Thank you. Lakshman, Dr. Rajagopal is a pioneer in palliative care. I think we should have mentioned about him.
All right, sir.
Okay. In Kerala.
Right. Thank you, sir. Yeah.
Sir, Lakshman, sir.
Yeah.
National anthem.
Oh, yeah. Thank you. Give me a few minutes. I'll do this, please. Yeah. Sorry, I missed that. Yeah. Sorry, I need to close this. Just give me, because I need to find that particular file, so it takes me a little while, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे